Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm good. It's good to see you on a nice Sunday morning.
It's nice to see you. How's your weekend been going?
Good. Good to be with the family. It's about to be a very different household. Maybe by the next time we record I will have two in college and junior in high school, and the landscape is changing.
Goodness, that is absolutely crazy. We're still we're still camping out in our friend's basement, but we do have a closing date in sight. So we're hoping by the end of the month we are up and out.
Oh, wow. Congrats. That's super exciting.
It is exciting. We did a kind of walk through the house last weekend. It looks amazing. We're very excited about it, but certainly it's come with a fair bit of stress to get there. So very exciting, very exciting. So hopefully next time we record we'll be closer to the end.
Well, if need any help on moving day, I'm happy to call Dr. Boyer for you.
I thought you were about to assign a medical student or resident to me.
No, I am more than happy to lend a hand. I really am.
Oh, I appreciate it. Thank you. I may just be parking my kids at your pool.
That's an option too.
So a
Oh,
couple of great reviews. I wanted to share one actually as a question. So this would be really useful for us to address. So this is from either Matt Rode or Matt Rody. I'm not sure how to pronounce it exactly, but 5-star review. Subject is a fountain of information. It says, "Hi, my name is Matt. I'm a second-year medical student at Mayo Clinic." I've heard of that place. "And hopefully a future orthopedic hand surgeon." You've got plenty of excellent role models up there at Mayo for you to work with. "The podcasts are so full of great information. I have to pause to make notes or flashcards. That is a first, and that is awesome. Keep it up. I was wondering if you could discuss your differential diagnosis for a patient with catching/snapping of fingers. And do you have any pearls for differentiating a trigger finger from a sagittal band rupture? Sincerely, Matt." So first off, Matt, thank you for that awesome review. It's amazing to hear that you're making flashcards from it. That is fantastic and definitely invigorating for us. Chuck, do you have any thoughts about the question?
well, it's a good question because we and I would think all hand surgeons have the potential to fall into this trap. Um, can get lulled into the sense of everything that pops is trigger finger. And we know one thing, and this is one of Dr. Boyer's um, teaching points, is that hand pain is often trigger finger even when you don't think it is, meaning that vague pain and you try to push on the A1 pulley. It's obviously a different category. So trigger finger can be more than we think it is. But when we hear catching of the finger or popping the finger, all of us immediately think of trigger finger. True?
Yeah, it's the MIB rule of hand surgery is it's always a trigger finger.
And that's what
But then I
happens.
think that I think the asterisk is not everything that pops is a trigger finger.
I think that's right. And not all of us have that population that he has. Um, so I think of a couple of different things. First of all, I always palpate the A1 pulley and ask the patient to demonstrate their triggering. A, the palpation may be painful, and B, obviously feeling the trigger can be 100% diagnostic. And then I do think about sagittal band ruptures, especially with a weird mechanism or an acute onset. And I think it's a matter for me, and I'd love to hear your thoughts as well. It's a matter of turning the hand over, asking the patient to make a fist, um, and watching that extensor mechanism, palpating the extensor mechanism, palpating for pain, typically over the radial sagittal band and typically the middle finger. That was a classic article by Kettlecamp that taught us that it's almost always the middle finger and it's almost always the radial sagittal band that's ruptured. Um, and then lastly, check and see if they can actively extend the finger, which again doesn't really differentiate it. Um, but passive extension is different, right? You can passively extend a ruptured sagittal band. You can't passively extend without a pop a locked trigger finger. So those are my brief thoughts.
Yeah, I think that the nature of the snapping catching is different, and you won't appreciate that unless you turn the hand over. So you're saying turn the hand over, meaning inspect the dorsum, as opposed to we're used to inspecting patients' palmar or volar surfaces. I think Matt, you're ahead of a lot of people just because you're recognizing the fact that this could happen. And one of the pearls that I heard in residency a lot is that the eye does not see what the mind does not know. So I think that it's fantastic that you're able to recognize that this entity exists. I agree with what Chuck said, and in terms of the atypical trigger finger, I think that it's the pain kind of shooting, or not shooting, but referred maybe to the PIP joint. But then when you palpate the PIP joint, there's no actual effusion or tenderness at the joint itself. And I've seen that in kind of the quote early stages of triggering. And I think that's described as kind of the maybe phase one or stage one of that condition, or pre-stage one, before there's any frank triggering.
Yeah, I love that. The other comment I will make is that the other trap that I should just not speak for all hand surgeons, I'll just speak for myself, is that when I see a patient and I make a diagnosis, it does set me up for future problems. And what I mean by that, if I see a patient and I call it trigger finger, well, before the resident or fellow goes in the room, the next time the patient comes back, they're going in with the mindset of trigger finger. Before I go back in the room on that second visit, I'm thinking trigger finger. And so if I misdiagnose the patient the first time, I definitely know it increases the chances of continuing that misdiagnosis moving forward. And where that's important here is with a failed corticosteroid injection. So if I misdiagnose a trigger finger and give the patient a steroid injection, and the patient comes back 4 to 6 weeks later and says, "Doc, that did not help at all," the compounding of the error is saying, well, let me give you another injection, or let me take you to the operating room and fix that trigger finger. I don't know why the steroid injection doesn't work. Steroid injections literally almost always work. They just don't always last. Thoughts on that?
Yeah, I actually was thinking about that the other day because I had a quote atypical presentation of triggering, and I went ahead and gave her the injection. And pretty much every time when I'm making the small talk about the injection, I give them the same spiel. In most people, it kicks in within 2 or 3 days. I've seen it take up to 2 weeks, which I've only seen it take that long one time. But I do tell patients I've seen it take up to 2 weeks for it to start to work. And if it's not working by 2 weeks, call, let me know so you can come back in and make sure that that we got the diagnosis right. So that's something that typically comes out of my mouth when I'm talking to patients about an injection. And the question I had for you is kind of a weird one, but I mean, in terms of when you're listing a diagnosis in the EMR for the atypical presentation of triggering, at least when I'm dictating a note, I typically will say, a bit atypical, but I think this is triggering. In the assigning a diagnosis, do you just put finger pain, or do you go ahead and commit and put trigger finger?
I commit. It's interesting because my mind goes in a different direction. I mean, in response to your question, I commit and say trigger finger for my diagnosis code. However, for my assessment and plan, I might say trigger finger, but somewhat atypical. I would just put a little, I would back off a little bit in my actual note. The flip side of that, of course, is carpal tunnel. I don't call it carpal tunnel until, if I'm sending a patient for a nerve study, I don't call it carpal tunnel until I have my nerve study results back. Maybe that's just, I don't know, probably doesn't matter. We're probably talking about something that the audience is rolling their eyes at, but I wait a little bit on the carpal tunnel diagnosis unless it's just crystal clear, unless I'm skipping nerve studies and planning for surgery.
Yeah, I guess I don't. Yeah, probably a little eye rolling from some in the audience, but there probably are some that do care about how we document things in the EMR. Because then, if you list a diagnosis, then it becomes part of the problem list, and then it carry into, you're talking about this compounding of issues and perpetuating. And I think that it's probably more of an issue if you put it listed in your actual billing diagnosis. But anyway, Matt, thank you for the great question. Didn't think that we could talk that long about trigger finger. And I don't think we've committed an entire episode to it, nor do I really want to.
No, no, agreed. And the last thing, just in closing, just to be complete, there can be intra-articular pathology at that MCP joint. It's pretty rare, but you can have an intra-articular reason for popping it, but it's just different. It's more pain and occasional popping. But I just wanted to close the loop there. Awesome. Thank you for the review.
Yes, and please, everybody, get on the iTunes and leave us the only option of 5 stars, and then you can ask Chuck a question, and we'll address it just like we did for Matt. So thank you, Matt. We love it, and good luck with the rest of the academic year. I think you're just starting off.
Absolutely. All right. I think today we are going to talk about a really difficult case. The segment you have entitled My Toughest Case. And
Yeah, it's my turn. It's my turn. And this one's funny because it's a case that I did not see in my fellowship training. But now I've done a few and I think they're really challenging. So this particular patient is actually somebody who's come to see me a couple of times and I've operated on twice now. And they have a condition called diffuse systemic scleroderma, and have with with Raynaud's now and ischemic pain, and a definite difference in the feel and the turgor of the fingers, but no frank ulcerations as of right now. But when they first saw me, they did have ulcerations, and they've tried all sorts of medical management, you name it, from sildenafil to obviously nitro paste, and they've tried everything else, and they don't have enough relief. How do you approach that scleroderma Raynaud's patient, Chuck? What's your treatment algorithm? They admittedly get to us late in the game, so.
well, I'll be very honest about a couple of things. The first is that for most Raynaud's patients, I send them to rheumatology for treatment, with the caveat that I'm happy to see them back. Patients get sent to us for all kinds of non-surgical reasons. And I think early in one's career, my general approach personally, and also I think it's just reasonable, is to see all comers, take good care of them, understand what you can treat and what you're not the best person to treat, and build your name in your community, build your reputation. At this point in my career, seeing a patient with scleroderma or maybe with Raynaud's, I might not be the best person to see them. Now I know where you're going with this case, I think, but I would say that for like a typical Raynaud's patient who's coming in for finger color changes and pain and cold weather relatedness, I would send them to rheumatology. Now, for this patient, I agree with kind of is what it sounds like you started with. You started with the basics, keep the fingers warm, mittens on a cold day, but more importantly, try to open up the blood vessels. And so use some nitro paste and consider a systemic calcium channel blocker. I would do those things for certain. Before jumping to considering surgical options, I would also think about Botox. And I don't know the literature as well as I could or should, and you probably have a better sense than me. But Botox has been demonstrated to be one reasonable treatment option. Do you have any experience with it?
Um, only to send patients for it. And honestly, it's sending them to back to their rheumatologist if they haven't tried that. But this patient doesn't come into my clinic very often, to be honest with you. And it's usually they are sent by their rheumatologist and they're done with all of the non-surgical treatments by the time they see me. And this is just one of those things where if you don't have this in your practice, somebody may come into your office and you haven't really assessed this patient before.
Well, that's the perfect scenario. And so, we've talked a little bit about relationships and what kind of relationships you can have with other physicians, other medical providers, and how they can help build your practice. And I've talked a lot about athletic trainers being one perfect example. Obviously, primary care physicians, concierge care doctors. There's lots of good examples of how you can build your practice. This is a perfect one. There absolutely should be a back and forth with rheumatology, not as robust as it used to be when rheumatology patients and those with rheumatoid arthritis really needed surgery regularly. But this is great. So this patient walks in, he or she has been maximally medically managed, and they're coming to you for a solution. So paint a little bit more of a picture of what the hand looks like, please.
So the pain is index and middle. Ulcerations at the very tip, kind of at the hyponychium of the index and middle. The index and middle feel different. They are not completely woodied or petrified, but they feel firmer. They don't have the same kind of bounce in the skin turgor. And the ring and the small are okay, and the thumb is totally fine. And then on the clinical exam, very easily palpable radial pulse, not a great ulnar pulse. And actually, I forgot that I have Doppler in my clinic because I think I'd seen a couple of these patients, and the last time I saw one, I didn't have Doppler in my clinic, so I made a big stink, and I got a handheld Doppler in my clinic. So now I actually went and used it. And you can hear the radial obviously is great because it's palpable. The ulnar is a little thready, but it's there, and you can kind of hear in a superficial arch, but you got to work for it. And then the radial and ulnar to the proper digital arteries to the index and middle are not great. The radial is, again, you got to work for it on the index, and then basically that second web space branch is not fantastic, and then the ulnar portion of the middle is okay. So I'm kind of in a jam, and I don't know how you counsel patients about what surgery is like and what to expect, and things like that.
Well, it's a great case, and in the right patient, I would consider surgical intervention. Um, and I have, it's interesting. It does raise the question of, in a group like ours, at a referral center like ours, should Chuck and Chris, and basically should all six of us do cases like this that are uncommon, or should we, have our micro partners do it? And obviously, you do micro a lot. I do micro some. And I certainly think it's highly appropriate for both of us to do it. And so I would, if I chose to handle this case rather than referring it, I would consider a sympathectomy. And when I've done those in the past, it can be fun, although it's not always a fun case. And B, you can make a big difference for this person.
This goes into the it's all good till it's not kind of case. Because
So
the friability of those arteries is real. I mean, they are not normal arteries.
lay all your cards on the table. So you decide, you're seeing the patient, you decide, yes, a sympathectomy makes sense. You talk to the patient, you schedule the case. How does Chris D prepare for a case that he doesn't do all the time?
You're actually getting. I won't answer that, Chuck, because that's
Uh-oh.
actually a topic for the wheel of hand surgery that we're going to record for next week. Preparing for new cases. So I will sort of answer it, but I won't give you the full. I won't spill all the tea here. I think that it's kind of hard because you're having to think on your feet in clinic because you have to tell the patient what to expect after surgery, but you yourself haven't had a ton of time to do the reading in the literature. You rely on your base of knowledge that you have from fellowship. So you're somewhat non-committal to the patient. You tell them what you remember the success rates to roughly be. And so I talked to her, I say, look, the very last option here, which I think is why you're here to see me, is to try to reinvigorate those blood vessels. What we do is that we think that there's essentially some spasming in the blood vessels coming from the nerve supply that that feeds into those blood vessels, and we're just going to separate the nerve endings from the blood vessel, and then also try to open up some space for those arteries. I tell them that they can probably expect some element of improvement, at least in the short term, in the pain, and hopefully some healing of the ulcers. But I think the recurrence rate is the thing that I worry about.
Yeah, well said. Well said. And I do think it'd be fun to talk about preparing for cases. I look forward to spinning that wheel. What's funny to me, you're going to roll your eyes. I know you are. So my 16-year old daughter talks a lot about the tea, which is like
Yes.
the gossip. And so I love that you worked that in. So correct me if I have the origin of this expression wrong. To me, it started with kind of the reading of the tea leaves, which I, kind of thought, I don't know if I really understood what the tea leaves were. And then I was watching, I don't watch a lot of TV, but I was watching Peaky Blinders maybe 6 months ago. And they actually, I guess it was a thing where people actually read the tea leaves in the teacup and kind of help understand the future. So I don't know if I'm taking this analogy too far, but that's what I thought of. And I'm sure there are listeners who love Peaky as much as I do.
You are absolutely taking it too far. I have no idea what you're talking about. I do know that the kids talk about the tea, and it is the gossip, but that's as far as it goes for me.
All right, sorry about that.
So what's been your experience in terms of how these patients do after a successful surgery? And we'll get into the technical parts of it in just a minute. But
I think your summary was a good one. I think certain patients, this can be a home run. maybe not lifelong, but you can really dramatically improve their situation. You can get the ulcers to heal, you can help the pain and set them on a different course. I do agree the risk of recurrence is very high. But that's why I say it is a procedure that I don't mind doing, because the results are reliable. And so I think you did the right thing for sure.
So when you book them for a sympathectomy, what does that mean to you? What are you intending to do and to which arteries?
So first of all, I book it on the main campus with a microscope. I don't know if that's 100% mandatory, but for me it is. And I book it for, again, I'm not in the OR every day doing micro, but I probably do book it for 2 hours. Now, part of that is just set up and the microscope, and so I
So
just
2 hours in the room.
2 hours in the room.
Okay.
And for me, that's a longer case. But
Mhm.
again, I don't want to be in a 2-room day trying to do a case like this, and I need to have a microscope. And then I would plan on addressing the radial artery and the ulnar artery, at least examining them in the distal forearm. And I'd follow the radial artery distally. And then I certainly would address the digital arteries from the arch heading distally. Now, for the radial index finger, obviously that may be a branch from the princeps, so may look a little different, but I would address all 4 arteries, focusing on the ulnar digital artery to the index and the radial digital artery to the middle. But it's a big case for me.
So would you book it on the main campus? Say, for example, say your surgery center had a microscope. Would you just do it there on a day where you're not as busy or at the end of the day? Or is you doing it at the main campus because you want access to other things, other people maybe?
No, I don't think I would worry about. That's a great question. I wouldn't worry about risks. I wouldn't worry about needing a partner. I don't think I would get into that kind of trouble. It's just a matter of being able to take my time and do the right thing in this case. I'm not worried about admission. So yeah, if my surgery center had a microscope and I could put it at the end of the day or in a protected time, I would do it there. I have no idea about reimbursement or things like that, but absolutely, I would do it. I would do it in an outpatient environment if I could find the right environment.
So, and then would you get an angiogram ahead of time?
I would not. I tend not to do that. I'm sure many would. And if any of our listeners have experience with this, we would love for you to share your thoughts with us. But I would, at the beginning of the case, really do a more in-depth Doppler exam than you did. So when the patient's on the table, I would plot things out. It would help guide my planning. But I would still plan on addressing distal forearm and also the digital vessels.
My Doppler exam was pretty thorough, but that's okay. So, so would you go into the finger? You know, you mentioned working on the arteries to the finger at the level of the distal palm. Would you cross that palmar digital crease?
I guess it would depend a little bit on what the vessels look like, but I traditionally have not. I work on the arch and I go out to the palmar digital crease. I don't typically go into the fingers unless A, I'm not making progress, and B, it seems like the vessels are more problematic distally.
So this is actually a case that I did a few years ago, and actually have now reoperated upon. But the patient at that point, we did what you described out at the level of the distal palm, and found those 4 arteries that you discussed. I did the sympathectomy, and then I did adventitial stripping for probably about a 2 or 3 centimeter segment for each of those, and did go out into the fingers. And I can't remember exactly now why I did that, but I'm pretty sure it was based on, like you're saying, the description. She did. Oh, and I did it at a surgery center because I have a microscope at my surgery center, and and honestly, that was a little bit of a fight to get that scope at the beginning, but it has opened up a lot of opportunities for me to do things with a lot of comfort out there.
Oh, that's so
Uh,
interesting. Well, I'd love to talk more about that. Keep going though.
we should. So she did great. She loves me for that, and the ulcerations healed, pain was gone. This was 3 years ago. She comes back recently, sends a few messages in the chart saying I'm not doing so great. We get her into the clinic, and the fingers are back to where they were. No ulcerations, but it hurts. It hurts a lot. I mean, she's like, starts saying the A word, that you don't want to hear as a hand surgeon. For those that aren't initiated, when a patient brings up amputation, you have to really pause a bit and realize that it's really bothering them. So we have the same talk about, how challenging this is. And now, if you've done the sympathectomy, there really is no reason for, spasm to be part of it, but all that scar that it's encased in can, choke off and scar those blood vessels and make it difficult for blood to flow through. So, the plumbing really gets messed up. So this time I actually, because it was a revision case, I emailed one of our partners, and David Bergen was kind enough to share some insights. And he suggested an angio because he had a case where a patient had an odd thrombosis in an unexpected location. And with that information, he had planned to do some vein grafting or arterial grafting versus vein grafting for that thrombosed segment. So we got the angiogram. Angiogram came back with no thrombosis, but an incomplete arch, great flow through the radial and not great flow through the ulnar. So with that in mind, we went back to the OR, and this was hard. The radial and the ulnar part, sympathectomy and, adventitial stripping, that all went really well, obviously, because those are bigger pipes. Went to the superficial palmar arch, and those looked fine. That arch looked okay, but then getting out to the radial index and to the ulnar index and to the radial middle, those were really diminutive and really caught up in a ton of scar. So that was really challenging. It almost felt like in a weird way, it kind of felt like a dupes.
And you did this with David?
No, David was around, fortunately, but I did not need David. David was going to be there. We are actually going to move it to David's OR if we thought we were going to have to do the grafting if there was a thrombosis. But we kept it in mind just because, logistically it was a little bit easier because there was no plan to do any grafting. Although I did talk to the patient and it was on the consent about possible grafting, even in the absence of a thrombosis, just because you never know how those vessels are going to handle.
Yeah, and grafting is really tough because even if you can, put it into the arch, for example, where do you tie it in distally if you have poor vessels all the way? So it's tricky and obviously not a situation you want to be in. Yeah, a revision sympathectomy is not something I've undertaken. Probably not something I would undertake, honestly. And do you have any type of results from operation number 2?
Very, very short term, we're happy, but nothing yet. And I think the proof will be in the pudding there in terms of, as the follow-up comes. And we've had this discussion that we're probably going to be in the same boat in terms of, we're battling a systemic condition and, this probably will recur and we're again running out of options. In prepping for this case and looking into literature, there was a really nice case series of revision sympathectomies that fortunately our colleagues at Wake Forest have published in the European Journal with, good measured, but good results. So I think that is reassuring. And it was a really hard case. It's just slogging through scar. It was one of those days that you come home just physically and mentally exhausted. Because you're like cricking your neck to get into different angles. We did it all under the scope in terms of the sympathectomies. I mean, the gross dissection we did on the loops, but the sympathectomy part under the scope. But the gross dissection was challenging. You're obviously working through tissue planes that are not normal. So then you're on edge, I think, for a lot of it. And it's obviously really small structures.
You probably had a very skilled set of hands to help. In that experienced fellows, I'm guessing. But these are the kind of cases that even if you don't technically need your partner, doing a case like this with a partner really can be a game changer in the sense of, two minds working together on how to address things, how aggressive to be. Technically, you're going to bring excellence with one of your partners. And just the interaction, I think we are both fortunate because we both operate with partners not infrequently. And I know that as I say, speak to the audience, Many people do not. And that is, while yes, there are financial costs to working together, there's nothing like it. I mean, it is really one of the joys of my practice when I get to operate with my partners.
Yeah, I think it's fantastic, and I enjoyed every big plexus reconstruction David and I will do together, and then I've been fortunate enough to that Lindley's asked me to come help her with some of the birth plexus, and it's just fun. Even if technically you can absolutely do the case on your own, and very beginning of my career, I did the plexus cases on my own, and then obviously had some help from like Marty. He would come in. I still remember asking Marty to harvest sural nerve, and still hearing about that story. Still hear about that now. But even if it's not for the technical things that David brings to the table in terms of being able to do the free functioning muscle transfers, et cetera, but just like you're saying, bouncing things off of each other. What do you think about this? Do you agree with that? In real time, it can be tremendously useful. So maybe we should do it more in terms of partners, but it is something that when it happens, it's absolutely worth it.
Right. There's an opportunity cost, but again, playing the long game, it makes cases, can make cases like that or other cases a lot more rewarding, and just builds that camaraderie, which I think we are so fortunate to have in our relationships. But good job. Sounds like a home run for the patient.
Yeah, we'll see. I mean, we gave it everything. So, revision sympathectomy. First sympathectomy. I think that in fellowship, I don't know if it's because of the way that the cards fell, but I didn't see it at all. I did it pretty early on in practice, one or two times, and now, first revision. But I think that the principles, in terms of technique and everything, just try to pick them up somewhere along the way. And if you're a fellow and you see these, if these are not cases that are common at your institution and you scan the schedule and you see somebody with it, go check it out. Or even a resident. Like, I mean, because I still remember cases from my residency that I didn't get to see during fellowship. So you never know.
Yeah,
You rather it be somebody else's patient first.
it's true. I joke about not doing much micro, and I prefer when my micro is elective. I don't know that I would prefer that this case be my elective micro.
Yeah, you probably will send that to one of our partners. So,
I almost definitely will.
all
All
right.
right.
Well, great. Let's get together again soon. I think the Wheel of Hand Surgery is going to be calling us.
The wheel of hand surgery. All right. I look forward to it. Have a good day.
Take care.